Okay, so happy Friday to everybody. How's everybody doing for this Friday?
Tired.
Tired.
It's
Great.
very, very dreary here. Snowing and
Yeah. Where are you located,
Ohio
Ohio, Centerville.
Dayton
Okay.
area.
Yeah. Okay. Now, we got an email this morning about some very kind of sketchy weather in Pennsylvania, and there were students without power. I see a lot of my Scranton students here, and Reese is here. He's from Essington. How are you guys doing in Pennsylvania with the power and the
Mine hasn't
weather?
been doing anything. It's just been raining, really.
Raining? Okay.
Mm.
Yeah,
Okay.
the power's been
Getting a
fine, but the
lot of
roads
snow,
are
but my lights keep flickering too.
Gloria, you're Scranton. Okay. Well, I'm
Yeah.
glad to see you here. So everybody is safe, right? That's
Yeah, we
here.
got a lot
That's
of snow.
got
At least, but
a lot of
yeah.
snow. Happy winter. Happy winter. I just want to make sure everybody from Pennsylvania is safe. Okay. Make sure you're not in the middle of anything that uh would make you unsafe weather-wise. We do have a plan. Um, Dr. Copteros, are you missing any of your students?
Jessica
I'm
meant
just looking now. I'm just looking now.
she's
Okay.
in the waiting room, I think. She says she got kicked out. She's waiting to get in.
Okay. I don't have anybody in the waiting room yet. So when I see her, I'll let her right in. Okay. Nobody's been kicked out. I don't know if she just dropped off. There she is. Let me let her in. Okay. Fantastic.
Thank you.
So yeah, I have everybody here, my students. Not sure about Dr. Copteros, but if there's any issues that are weather related with regards to attendance and quiz it for quiz five, weather related, we'll work it out. No worries. Okay. Um, I've been in communication with Dean Brown. Okay, we'll get everything worked out. Um, okay, so couple of things. Dr. Kapteris is going to teach class today. I just wanted to go through some housekeeping announcements before we take the quiz. Okay, so today is our last quiz, quiz five. If everybody can come on camera, that'd be fantastic. So you need to be on camera to take the quiz. Okay. And I'm gonna have Dr. Kapteros have monitor that. So a couple of things. The first and foremost is next week we do not have class. It's a holiday, right? It's the Thanksgiving holiday. It's the reason why this class has 10 minutes added on to every class. Right. So next Friday there is no class. So a couple of options for you. You don't have to make it up. Okay. So there's two options. Well, one is kind of a given. We will be sending you the recording of our Monday class next week. Okay. So you have a recording of the week 9 content. Okay. The other thing I'll offer, and I always do when we have a holiday that falls on a class day, and I'll do this in an announcement. Anybody, and so you don't lose any attendance next week. It's a holiday. Okay. You'll get a recording from our Monday class. I'll send that out by Monday or Tuesday. So you have that. The other thing I always offer students is if they would like to hear the content live, listen to a live lecture, you're more than happy to come to our Monday class or our Tuesday class. And I'll send out those times of class in an announcement. Okay. Mondays, our class is at 3 o'clock Eastern time. Tuesday, my class is at 1 o'clock, but I'll send out an announcement. Okay. Thanks, Dr. Copteros. We'll just have to determine if it's a power issue, weather issue, and we'll work with that student. That's awesome. All right. So does that sound like good options for next week? All right. But you don't have to attend a Monday class, not a Tuesday class, but if you want to hear it live, that's perfectly fine. And then you'll get a recording. All right. Okay. I have had students, a couple of students from this class request to take, I think, exam 3 on campus. That's perfect. And the students have gone through and found a proctor and it's all set up. If you are a student that is part of that and wants to take it on campus, you just got to reach out to either Dr. Kopteros or myself and let us know. We just need to have a documentation trail that you're going to be taking the exam on campus, okay, with a proctor. So the two students that have reached out to us, we're all set. It's all organized. But if anybody else additional wants to be taking their exam on campus, you just got to let us know and let us know who your proctor is going to be so we can coordinate with them. All right. Okay. Exam 2, if you score below a 78, and actually, let me start by saying, for the most part, students did fantastic in this class with exam 2. So congratulations. And I think Dr. Kopteros would second that. Congratulations on a job well done. Very, very proud of you guys. Okay. I know some of you didn't attain the grade that you probably wanted. And that's where we are here to help. So for any students that received below a 78 on exam 2 and or received a mid-module assessment in the last week, Dr. Kopteros and I need you to reach out to us and schedule a time to review your mid-mod assessment and have a look at exam 2 and where you struggled. Okay, a lot of students have already reached out to us and we have times and appointments scheduled with them. So thank you for doing that. But if you haven't yet, pardon me, please reach out to us. We definitely want to get to you before exam 3. Okay. The next 3 weeks in this class are going to get busy. Okay. This week we had a quiz. You'll have a quiz. Okay. And that's it. We're done with quizzes after this week. But the next 3 weeks get busy. Next week, week 9, there's 4 things going on. Case study, NCLEX, your HESI prep assignment, and next week is our exam reviews for exam 3. Okay, because exam 3 is in week 10. All right. I'm going to change mine. I have to find another day. Mine is scheduled for next Friday, which is a holiday. And if people are busy for the Thanksgiving weekend, I don't want to waste that review. I'm going to move mine back to sometime probably Tuesday, maybe even Wednesday. I think I have to look at Professor Ford's. I think hers might be Tuesday. I may do mine Wednesday instead of Friday. And then Dr. Kopteros does hers Sunday evening. Okay. So be looking for an update on my review for next week. So that's the 4th thing for next week. Exam reviews, case study, NCLEX, and HESI prep. Okay. And then we jump right into week 10. Week 10 is an exam and your vulnerable populations assignment is due. And then we jump right into week 11, which is HESI, and you have an NCLEX, your last NCLEX. Okay. So just be mindful the next 3 weeks get busy. And I know you know this from looking at the schedules and what's due in your modules and the syllabus. So just want to remind you of that. ExamSoft update. If you haven't gone in and you had an announcement about an ExamSoft upgrade, please go in and do that mock exam. Okay, it's 2 questions, doesn't take long, and it validates it's a software update. It makes sure that your computer compatibility is okay with ExamSoft. Okay, and the reason why you should do that, even if you've had no changes, go in and do that. Because if we get to exam 3 and you're having technical issues, and you haven't done that mock exam to validate your connections are all fine, we're going to have to reschedule your exam. Does that make sense? So best to take 5 minutes and do it. Okay. And that's different from the beginning of the term when we opened up the practice ExamSoft exam, because ExamSoft has done upgrades since then. So that's why you're being asked to do it now. All right. So take the time to do that. Speaking of NCLEX, my Monday class requested that because week 8 was a light week, if we would open up our weeks 9 and 11 NCLEXs early so you could work ahead. We have done that for you. Some of you may have already figured that out. But your week 9 and week 11 NCLEX are already open, ready for you to do if you would like to work ahead since the next 3 weeks are so busy. Okay, so that is available to you. There's one question on this quiz that you're going to get credit for. It's question number 2. It's keyed in incorrectly. So just FYI, and we'll go through that. Dr. Kapteros can go through that when she goes to, I think it's question 2. It's about the vaccine for a pregnant mom. Everybody will get credit for question 2. Okay, so just ahead of time, letting you know that. Dr. Kapteros, what am I missing for updates? I catch everything?
Yeah, you did good.
All right, any questions before we start the quiz? No questions? Okay, so let me put in the chat the access code. Whoops, let me get to is my last name. Everybody who tried to access the quiz before 4 o'clock, you're going to have to refresh. Quiz 5 should be available to you. It's 15 minutes. So it's 4:11 now. Everybody be ready to go by 4:30. How's that? So stay on while you take the quiz. You can go off camera, but be back and ready to go at 4:30. Any questions? We're going to mute ourselves. So any questions in the next 15 minutes, just put in the chat. Sound good? Fantastic.
Amanda, your video was off.
I just messaged Professor Marvel. My computer crashed and I'm trying to reboot it back up.
Okay, are you going to take the quiz?
Yeah, I'm trying to hurry up and reboot it.
Hi, Dr. Cupteros. I think everybody looks done. Are your students done?
Yes, ma'am.
Okay. You're free to go.
Okay, let me get this out of the way. Oh, oh yeah, I can share my screen on this, right? Okay.
You should be able to share
Okay.
your screen. I made you a co-host. Yep.
Yep.
Okay.
All right, so here's week 7. Oh, first we're gonna go over the quiz. I'm sorry. So the quiz, so the first question had to do with a 16-year-old female. Wait a minute, this is question 3. The school nurse notes several children developing pustular rashes on their face and extremities, accompanied by several days of a fever and malaise. So this is a reportable illness. It could be either chickenpox or smallpox. Now, some states have county CDCs, some have state CDCs. And then there's the national one that's in Georgia. But here in our state, we don't have a county CDC, so we report to the state. But and then it's good to know that the difference between chickenpox and smallpox looks very similar. But chickenpox you'll also see them on the soles of the feet, whereas smallpox you won't see them on the soles of the feet, and I don't think you'll see them on the palms of the hands. So that's something that you can keep in the back of your mind if you're a school nurse. Now, if any of you guys chose what the quiz stated was the correct answer, rubella, please go back and study your vaccinations, because only the influenza on this list would be safe to give a pregnant woman. So, and this is with her first child, so she wouldn't even need the RH factor in there. So yeah, remember, like rubella, varicella, all those Ellas are very bad. Measles, MMRs are very bad. Then the third question, the health department is caring for a 16-year-old female, new diagnosis of gonorrhea. She should be aware that if she ever develops an abdominal pain or fever, she needs to report it to her provider, because that area is very vascular and you don't want that infection to get into her bloodstream. So that needs to be promptly reported to her provider. And if you're an occupational health nurse and you're taking care of a workplace injury that involves a needle stick or even bloodborne pathogens, for anything that needs to be tested with HIV, because there's an incubation period, it probably will not show up for at least 3 months. So they always need to return in 3 months. Now they may insist on having, and some facilities will have you do on the day of your finger stick, but that can be a false negative. You have to wait for the incubation period to be over before it's going to show up in the blood. Okay, so this fifth question, the nurse is developing a primary prevention program for TB. The intervention that would be most helpful for her community would be to make sure there's no overcrowding in homeless shelters. Also work with prisons, look for tent cities if there's people that are living, a lot of people in one small tent, which they may do if they're cold. If the prisons or homeless shelters cannot accommodate, like taking less people in, but at the very least, they should put the people that are positive in one area and the people that are negative for DB in another. Now, one of the student asked me about dormant, any TB that they used to have that they no longer test positive for would be dormant, so they would not be contagious. The home health nurse is visiting a client recovering from right hip replacement, and that was done 8 days ago. So they're complaining of pain in their left calf. Now that is if you look for redness and edema, that's typical signs of blood clots. So they're very prone to that. Even though they wear the elastic stockings and they do their physical therapy and they elevate their leg, they're still very prone because there's sediment, because after the surgery, even though we want them to get up and walk, a lot of them won't because of the pain. So they're very prone to becoming stasis, venous stasis, which is going to present with a blood clot. The home health nurse is caring for a client with chronic peripheral arterial disease in both legs. Which client education should be included? So basically, a lot of those were correct. Stop smoking as soon as possible to improve blood flow. Use compression stockings to reduce dependent edema. Position a pillow under your knees while in bed. Elevate both legs anytime. Elevate the legs anytime when you're seated. Those are all helpful. But if you're still smoking, none of those interventions are going to matter because you're constricting your blood vessels from inside the body. So anything that you can do to your body from the outside is not going to help if you have something ruining your veins from the inside. So that's one of the things that you would want to stress with a person who has PAD or even PVD. For dietary accommodations, COPD people, usually you see them, they look emaciated. They are very dyspneic on exertion. That includes just going to the bathroom. It includes getting up to get a glass of water. And it also includes eating. So you want to provide rest periods. They should rest before a meal. And if they become fatigued while they're eating, have them rest and then reheat the meal and give it to them later. But they need to get their nourishment. I have a lot of clients with COPD that will drink Boost, the nutritional drinks, because they just don't have the energy to eat a meal. The home health nurse is caring for a client with cirrhosis who lives alone. Now, this one would be to evaluate gait and environment for risk factors, because now people with cirrhosis, a lot of them will have thin arms, thin legs, they're thin in their neck area, thin faces, but they have ascites, so they have this huge belly, which can be even bigger than a pregnant woman at 9 months. If you cannot see your feet, then you can't see what's in front of your feet. So especially if you're walking down the stairs, you want to make sure there's nothing on the stairway because they'll trip on it. You want to make sure that the oxygen tubing is away from where they can see it. I've had some clients that will put the oxygen tubing like up around their neck so that they know that it's behind them. Also, if they have throw rugs, which you want to get as a home care nurse, you try to get them to get rid of those right off. But if the corner is folded up, they're going to trip over that. If they have a low magazine rack or a coffee table, they can trip over that. Whatever, if you cannot see your toes, then you can't see what's in front of your toes. So that correct answer there was to be evaluate the environment for risk falls and their gait. Which food should be avoided by a client with poorly controlled hypertension? Obviously, it's canned fruit, because canned soup, canned fruit, canned meat, anything in a can is preserved with salt, and we want to keep these people away from salt. I did have a client who used to eat a can of soup every night for her supper, and she could not afford to buy the sodium free. She used to take the can of soup in the morning, and she would pour it in a bowl, and she would put a potato in that bowl. The potato, through osmosis, would suck out the sodium from that soup. So it was low sodium by the time evening came and she ate it for supper, which is always a handy trick that you can teach your clients.
That's interesting. I actually never knew that.
Yeah, because salt, where salt goes, water goes. So, yeah, potatoes are very watery. Like, we grow potatoes here and they need a lot of water to grow. So anything will cross that barrier quickly. Any kind of, salt. Any questions on any of these items?
The question that you guys have to correct, that'll be corrected by tonight, or?
Yeah, no, I had started correcting them, but then you guys finished the quiz. But yes, it's going to be corrected right after class for both of us. Well, Professor Marvel might be doing hers now, but I'm going to wait until after.
No, I
'Cause I'm
haven't done
talking.
mine, but just know
Oh.
that everybody will have a credit for question 2.
Yes.
When we get to it. I'm hoping to get to mine sometime today, but you'll have credit for question 2.
Yep.
Thanks.
So I hope you got it wrong because that makes me feel that you're safe
Oh, I
enough.
absolutely did. I worked in maternity. It's flu. I already knew that.
Yeah. It's the people that would have gotten it right that I would be kind of concerned about. Okay. So now we'll go into week 7. 7, my screen's being shared, right?
Yes.
Okay, thank you. Week 7, it says here that we have the concepts of community-based nursing, which include infectious disease prevention and control. We're going to look into HIV, TB, sexually transmitted diseases, bioterrorism, and disaster. For here, it says for each of the following infectious disease prevention and control concepts, define, discuss, and give examples of the following. Discuss the epidemiological triangle. So you have the host, you have the agent, and you have the environment. So I kind of like to put this in the concept of, how come that's changing on me? In the concept of a pregnant woman, okay? So a pregnant woman, let's say she's the host. If you're hosting a party, you're the one taking care of everyone. So she's the host of this embryo. Now, the environment would be what kind of environment will help that child grow? That would be, first of all, the sperm would have to make it to the egg. Then that would be like an incubation type period. The egg would have to find its way through the fallopian tube, attach itself to the uterus, right? So now the 9 months is while the baby is incubating. So that would be, all of that is included in the environment. The agent, how do I say this? The agent is the baby itself. So with bacteria and viruses, the person who is carrying the virus, let's say, is the host. They're hosting this virus. If the environment inside the body is just right for that virus to survive, it's going to grow. The agent is what it needs in order to grow. So then now you're talking about, I don't want to get too deep into it, but now you're talking about antigens and antibodies. Okay. Also, it's the microbes that cause the disease. So, geez, I don't know how to get into this without going into B cells and T cells, but anyway, it's complicated, but it can be easy. The host is the person that has the illness.
Basically, you just
environment-
need all 3 of these to make it,
Exactly.
to the infection or
Exactly.
whatever. Yeah.
Yeah. So you have the virus, which is the agent, going into the host and then incubating in there, and then the environment is either going to make the host grow or it's going to kill the host. I mean, make the virus grow or kill the virus. So I don't want to confuse you guys. Do you kind of understand this?
Can I
You're
jump
making it
in?
make sense.
Can I jump in and give a different
Okay,
example
sure.
too?
Already.
Yep. So that's an awesome example of the baby in utero. Let me give another example outside of that. Let's say you have a virus that's COVID. Okay. So the agent is COVID. The host is who? Is it young, healthy kids? Is it elderly compromised? Somebody elderly compromised? Is it somebody who's immunocompromised? What's the environment? Is it a long-term care facility? Is it a rehab facility? So take COVID. Just quick example. How did COVID affect the elderly versus the young, healthy kids?
It affected the elderly more because they're immunocompromised. Their immune system sucks.
Okay, they're immunocompromised, they're older, they may have other comorbidities. And so the agent was COVID, the host was the elderly or the healthy kid, and the environment was wherever they were. take an elderly nursing home versus a high school. Okay, so the point of the epidemiological triangle is there can be many combinations of an agent, a host, and an environment. And that's what we need you to understand is all three have to be present, and all three will direct how sick somebody gets, if the host is unhealthy, if the host has comorbidities, if the host is obese or has substance abuse, mental health issues. It's all going to look different. You got to take all three into consideration. Thank you.
Thanks. Very good.
Yeah.
So now host factors, there are host factors that can increase the resistance. For example, if you have vaccinations, if you have good nutrition, adequate rest, physical fitness, and you lack underlying, as Professor Marvel was saying, that you don't have any comorbidities, and also you have good hygiene. You have, now there are different types of immunity. Passive immunity is where you acquire the immunity from someone else. It can be from your mother, or it can be administered through IV antibiotics. Your body is being assisted in getting rid of the bacteria. So that would be passive. The body is working, but it's like you can get passive immunity would be in the mother's milk, okay? Acquired immunity is when you actually get an infection and or you get a live virus vaccination and you build up your own antibodies to it. That's an acquired immunity. Herd immunity is immunity when a population of people are protecting those that aren't resistant. So if you are, like I was saying in the quiz, if you take the people who have active TB and you put them in one section, and then you keep the people without active TB in another section, that would be an example of herd immunity, meaning you're keeping these people, you're protecting these people away from the people that have the disease. Then remember that there's an incubation period. Now, during the incubation period, some bacteria can be, you're usually not contagious, but there are some on a rare occasion that still can be contagious, like a person won't even have the symptoms yet and they can still give it. But the incubation period is you have the illness, but you don't have the symptoms yet. It has to grow. Another example of that would be, like if you're on Coumadin, say, and you have to have an INR, and you have your own INR machine, which is like the glucometer, and you check your INR. And I was working with this one doctor, and he used to always, like, if the INR was low, he'd change it the same day, and if it was high, change it the same day. But it takes a while to build up in your blood. So all of this was too labile. It was just too much change. So you have to wait for that incubation period to end before you can actually treat it. Once the incubation is done, the baby is ready to be born. Now you're communicable. Now you're going to expel that to other people. Now you're going to have the birthday party for the baby, right? So that is your communicable period. You're going to be contagious until you're on an antibiotic for X amount of days, and each antibiotic works differently. So, like for COVID, it was 2 weeks. You had to be free from symptoms for 2 weeks, or where I worked anyway. Now, the communicable period, it can be during the transferring of the infection. It can be direct transmission, or it can be indirectly. Now, you have some that are touch. There are some viruses that will live on, like TB will live for 3 months, outside on the grass. Some will live for days. If you want to make sure your patients get MRSA, throw some antibiotics in the garbage can and let's wait and see what happens then. So there's an incubation that would be indirect contact. Contact would be like STDs through serum, and things like, more through water, through blood, sputum, semen, all of that stuff, that would be direct contact. They don't even have to walk to their sled in the winter. They've got their sled right with them. So, that would be important to know during the communicable period, because there are some, like staph infections, bacteria that live commonly on surfaces, like your desk that you're sitting in front of right now, that has staph on it. Now, if you have a cut and you're immunocompromised, you could catch a staph infection just from touching your desk. That would be indirect. An epidemic is when the disease is within an area, and the people have close. It's, I don't know how she wrote that. There's a higher incidence of a particular disease than there should be. That would be an epidemic. All of a sudden, you have 1/4 of the population in this town has TB. That would be an outbreak. So now you have an outbreak, which is going to turn into an endemic. And an endemic is a disease that is affected by the population in one area. Pandemic is when it's all over the world. Like it's not just in a town, it's not just in a state, it's in a bigger area. So an epidemic is not as bad as a pandemic, and an endemic endemic isn't as big as an epidemic. Does that make sense? An endemic is going to be in the town, or with a certain population. An epidemic is going to go from one population to another population, and then a pandemic goes to every population. So let's say you have an outbreak of TB in the homeless shelter. That would be an endemic. That's going to be confined to the homeless shelter. Epidemic is when it's spread to the people on the bus. So now workers are getting it, right? So now it's going to be an epidemic, because now anyone can catch it. And then if these people get on planes and they start traveling the world, or even the country, now it becomes a pandemic. Is that right, Professor Marvel?
Yes. And
Okay.
the other thing I describe as something that's endemic, an example of something being endemic is like COVID and the flu. It's always going to be around, right? We've eradicated a lot of things by vaccines, whatever. But the big difference between endemic and epidemic, like Dr. Kapteros said, it's a very big excess of what is the norm. Let's say you have a flu season that, let's say the typical is 20% of people are going to get proper influenza. We have a season that 40%. That's an epidemic. It's way in excess of what was expected. And then endemic, again, like Dr. Kapteros was saying, it's something that's not eradicated. It's always, the flu is always going to be around. What can we do to help ourselves, protect ourselves from getting sick? Maybe we get the vaccine. Maybe we're not around sick people. Okay, does that help?
Thank you.
Yep.
And then the other thing we always want to remember as a nurse, and also to teach our patients, is hand washing is the best way to prevent infections or spread of infections. So as long as people are washing their hands, they have less of a chance to pick up anything that is in the environment, whether it does, even if it's on the surface, any kind of bacteria that's on the surface. Always wash your hands before you put on gloves. Wash your hands after you take your gloves off. Wash your hands between patients. You don't need to cross-contaminate patients. We had an incident. We never saw MRSA here. And then there was one nursing home that had a patient with MRSA, and we had an outbreak here. Basically, the whole county was MRSA. So washing your hands is very important. So we talked a little bit about passive immunity, acquired immunity, immunity. So we'll skip that because I want to get to week 8. Now you have vertical versus horizontal immunity. Whoops. So vertical is when it's an illness or it's a disease or a virus that comes from your parent down generations. It can be even a condition, like two recessive genes will make certain illnesses and that can be passed down. Horizontal is when it comes from person to person. It's not someone that came before you. It could be a sibling, it could be a friend. So you like a mother can transmit HIV to her unborn child. That would be vertical. Now, the unborn child can grow to be an adult and can pass on HIV to a sexual partner. That would be horizontal. Does that make sense? Okay. And you can look at that the same way as far as immunizations. If you want to get a vertical immunization, breastfeed your child because the child will pick up whatever you're immune to in your breast milk. Okay, so chlamydia, gonorrhea is bacteria and that's spread through sexual contact. It's treated with antibiotics. Sexual contact should stop completely until the illness is cleared. All sex partners need to refrain from sex for at least this illness lasts 60 days. And a person should be tested and treated as soon as possible. A person may have symptoms and they may not have symptoms. It can cause pelvic inflammatory disease because the genital areas are very vascular. So when you have pelvic inflammatory disease, that can go straight to sepsis if it's an infection. But most often, PID leads to infertility. It can lead to endometriosis. It can lead to adhesions in the pelvis, and also can include death if it's not treated. Now, syphilis begins with a painless sore or canker, and it moves into the lymph system just like the flu would. And just like some cancers, like your lymphomas, they start as actually just similar to a virus, these cells come into your body, they learn what is normal to your body, they hide themselves as part of your body doesn't recognize them as enemies, so it feeds them. So a lot of people with cancer the better their nourishment is, it's feeding the cancer cells too, because these cancer cells have put a mask on and they've tricked your body into thinking they're normal, So if syphilis is not treated with antibiotics, it will go from the primary stage into the secondary stage. And that's when it may become latent or it can reactivate later in life. So that can cause severe damage to many parts of the body. At that point, it cannot be cured. So that would be tertiary when it spreads to all different parts of the body. Was it Beethoven became blind from syphilis? And then positive serology will indicate that syphilis has progressed to the secondary stage. Herpes simplex and genital herpes are very similar. They're cankers. They are viral. There is no cure for them, but they go in and out of remissions. You can have an exacerbation and a remission, like people who have canker sores when they're under stress. I've heard many people say when they're under stress, their canker sores are worse than when they're not under stress. So these blisters can also appear around the genitals, and that they can be contagious at that point. Whenever there's open drainage, even if you kiss someone with a canker sore, you can get herpes simplex. But the herpes virus is also seen in chickenpox, and it's also seen in shingles. So let's say you have chickenpox, it lays dormant in your body. But if the conditions, if the environment is just right, an internal environment is just right, it can turn into shingles, which is herpes zoster. So, you want to prevent that with the vaccination. The blisters will ulcerate and they'll last for several weeks. The virus will move into the nerves and reactivate repeatedly, and that is very painful for especially people with shingles. They can be suppressed with antivirals, but again, they can't be cured because it's a virus. And it can also be passed on through vertical contact during birth of an infant. Genital herpes may be spread during outbreaks, and it's possible to spread the infections with viral shedding between outbreaks. Herpes is lifelong. It's a condition you'll have the rest of your life. There is no cure, but as we said, that there are treatments that can put you into a remission for quite a while. Some people can live with it quite well. Clients with genital herpes should inform their partners of the disease to help prevent transmission. Petroleum products should be avoided because they can cause the virus to spread. So the notion that genital herpes is only transmittable through visible lesions or when visible lesions are present is false. Anyone not in a long-term monogamous relationship, regardless of their health status, should follow safe sex practices. So even if you don't have the symptoms, if it's laying dormant, you're still considered contagious. Hepatitis is a viral illness, and that attacks the liver. Hepatitis A is spread through fecal, oral contact. There's a higher risk in men who have sex with other men. There's a high risk in daycare workers and attendees. Illegal drug users, those with chronic liver disease, those in countries with Hep A, where it's common. And then where vaccination is unavailable.
Professor K, I have a question. Did you change the slide?
Oh, I'm sorry. Okay, it's old age. I'm sorry. It's just old age. It's just nervousness. I'm being watched, you know?
It's all right.
Okay, so standard precautions. We talked about. Oh, we didn't talk about airborne yet. I sent you guys these slides, right? Okay, let's do that later. Okay, so we'll talk about hepatitis B now. Hepatitis B is the one that can be prevented with vaccinations, immunizations. It's spread through, it's bloodborne, and it's common with IV drug users, people with STDs or multiple sex partners, those in countries that have higher rates of Hep B. Also common in healthcare workers. Usually the facility you work for will provide you with the vaccinations for that. Inmates of long-term care institutions, it's common. It can live on the surfaces for a week. So that means if someone with Hep B happens to have an open wound and they touch something and nobody notices that there's microscopic blood there, and you go and you have an open wound and you touch that surface, you can get it. Vaccines are given starting at birth, and they can become chronic for those with immune deficiency. I don't understand. Professor Marvel, I'm really not understanding the sentence. Vaccine given starting at birth can become chronic for those with immune deficiency.
Where are you reading that from?
Your blueprint.
Let me pull up my blueprint notes. When I discussed vaccines with the class on Monday, Here was the message I sent about vaccines. Let's see. Vaccines, as we know, and what we teach our clients. Get to my vaccines page. Yep. Hold on. Vaccines. My notes that I taught on Monday were that we know that vaccines are one of the most effective methods in preventing and controlling communicable diseases, right? And so the scenario I presented to my students, our students on Monday was, what do you do if you have a family or parents that don't want to vaccinate? What's our approach? What should our approach be?
Give them data to support the vaccine and how it's helped versus, or the rates of how it's helped per se.
Also,
Just-
you can explain to them that just because other kids are vaccinated doesn't make their kids safe, because those are still out there. Those,
Right.
Yep.
And Destiny put in the chat, educate. So what don't we want to do? Let's say you have parents that, let's say you're a school nurse and you don't have, kids don't have vaccinations, certain kids. What do you don't want to do?
Make them feel like they're different.
Be judgmental, right? Try and force them to believe in a certain way. So the long and the short of the vaccines are, and this is what we want you to know for purposes of this class, vaccines are one of the most effective methods of spreading infectious communicable diseases. Look at some of the vaccines, the MMRs, the measles, the all that, right? But we can't be judgmental. Parents have the opportunity to do exemptions, personal exemptions, religious exemptions, medical exemptions. Like you said, all we can do is educate. But we have to have a plan in the school settings if kids aren't vaccinated and there's an outbreak of, say, pertussis. Okay?
I think the biggest risk is that since there are more people not getting vaccinated, these illnesses that people who are vaccinated think have been eradicated, polio, mumps, measles, all of those things. You cannot become complacent, even if you have been vaccinated, because these viruses will mutate. So even if even if you've had your vaccinations, because there are so many people not getting vaccinated, they are giving the viruses an opportunity to study us, to study our vaccinations. Basically, that's why we have to have a different flu shot every year, because the virus picks up on what our flu vaccine is. So then it changes its own makeup so that it will trick our body into thinking that it's not foreign. So people who don't think they can ever get polio can still get polio. So they still need to practice safe aseptic technique. They still need to wash their hands. I mean, when COVID first went away, look, it came back again because people got complacent. So yes, while you should not ever discriminate against someone who is not immunized, you also have to keep in mind that this is the environment that the viruses use to mutate themselves, to making themselves immune to our immunizations, so that our immunizations aren't going to pick up on them. In years down the road from now, when you guys are my age, you're probably going to see variations or mutations in viruses that I wouldn't even dream of right now.
And the funny part is nowadays too, when parents don't get their newborns vaccinated, some pediatricians actually refuse to see them now because they won't vaccinate them.
Right. Yep.
I mean, 'cause technically we can still, even if you're vaccinated, you can still get it. It just, you won't be as,
Well, you can get it if it mutates.
Yeah.
Our vaccinations were based on whatever the virus was composed of at that time. But it's just like I was saying, if you're gonna when you're flushing your tubing of antibiotic and you're flushing it into the sink, or you're flushing it into the garbage can or on the floor, that's giving that virus an opportunity to say, hey, This person hasn't had this antibiotic yet. Let me see what this bacteria is doing and our virus, and I'm going to change myself so that this one isn't going to know I'm here. It would be like if you were in a war, you putting on the opposite side's uniform and going to their camp and then blowing their camp up because they don't see you as the enemy. And that's what viruses do. That's how they've survived all these decades.
Oh yeah, and I
Uh,
agree absolutely, even if you do or if you don't. But what I'm saying is just like now over time things are changing where pediatricians prefer you to do vaccinations than prefer you
right,
not to. That's all I'm
right.
saying.
Right. You're correct. They're just trying to nip it in the bud because they don't know what's coming down the pike. None of us can know what's coming down the pike. But then again, it's like when you're dealing with religion and culture, you cannot disrespect someone else's culture. You cannot make that yours is better, but we all have to be aware of this and make sure that we don't get complacent. That's the major thing, is not to become complacent. So all of the hepatitis A, B, C, they can all be prevented through immunizations. So HPV virus, that is spread through sexual contact. The hard thing about getting the immunization is that it's given at such a young age that a lot of parents don't feel that their child should have it because they're not sexually active yet. But the thing about oh no, this isn't the HPV. Yeah, HPV is that it can turn to cancer. But I'm ahead of myself. This is HIV. So we all know about HIV. It's bloodborne. The most important thing to know about HIV is the incubation is 3 months. So chances are it will not turn up for 3 months. You'll get a lot of false negatives in that time. Clients need to understand that the HIV test cannot identify infections that may have been acquired within previous 3 months. Now, some facilities will have you, if there's like a needle stick, they'll have you get an HIV test immediately, but you still have to return in that 3 months. 3 months you may be negative. Some facilities will say, well, you have to return every 3 months for up to a year. It depends on your facility on how they do that. But the 3 month is the one that you want to remember as a nurse. That's when the incubation should be done by then. And then TB, tuberculosis, is a microbacterial disease and it's airborne. So I don't remember seeing these slides on Monday. I must have been sleeping during your class, Professor Marvel, because I don't remember these slides.
I didn't pull up this long PowerPoint for week 7. I kind of gave a summary of it.
Okay.
So you can kind of there's so many, you can kind of quickly go through it so that we can get to week 8 material.
Okay, I'm just going to go through the information and not the slide.
Mhm.
I'll stop sharing.
Yeah,
You
sure.
guys all have the PowerPoint show
Yeah,
anyway.
you all have
We
it.
have
Yep.
eight slides left, so I'm
Mhm.
going to stop the share.
Okay.
Okay. Okay, let's talk about bioterrorism and disaster management. There are natural and there are man-made disasters. Natural would be hurricanes, blizzards, earthquakes, erupting volcanoes, things like that. Those are natural disasters. Man-made would be nuclear war, a leak at a nuclear plant, a factory that spills in poisons into the water system. Those are man-made disasters. These events directly impact humanity, and and also it can be seen as pesticides that we talked about, pollution. Those would be man-made. So when you're teaching a family on how to prepare a kit for a disaster, you should instruct the family to stock enough food for 3 days and review the kit every 6 months. Ensure that all of the family members know where the kit is located and learn how to turn off the utilities in the house, especially the gas, and then review the supplies every 6 months to verify that none of them have expired. Even canned goods have an expiration date. So you want to make sure that the families are prepared for any disaster. Even if it's not a natural disaster, we cannot predict man-made disasters. We can't predict somebody setting a local gas station on fire and having it blow up for 2 or 3 blocks, right? Now, mass casualty, that is a lot of people have the mass casualty exercises that I've been a part of from our hospital. And that's when you evaluate how your response system is working and you tweak what worked well, what did not work well. You identify your priorities, how much time it takes. Like when I was in a disaster, anyone that was not at work had to be on call, but you weren't on call like to go home on call. You were not, you were just off. But the hospital would call you, you would have less than an hour to get in. They would even send police officers. I know one time in the winter, there was a real problem where there were a lot of accidents for this county, and the hospital nurses couldn't get into work, and they were sending the cops out, state troopers out to pick us up because we couldn't get into work. But the mass casualty exercises, you will probably find yourself a part of it if you work at a facility. And everyone has a designated place where you meet, and then everyone is given a task to do. Some people will be it doesn't matter what floor you work on. Some people will be just transporting. Some people will be triaging. Some people will be working with minor injuries. Some will be working with moderate injuries. Others will be working with people who are fatal. There'll be more help that will be needed in the operating rooms. So you have to go into a mass casualty not as, well, I'm an OB nurse or I'm a pediatric nurse. You are simply a nurse. So you need to fall back on everything that we're teaching you in this program so that you can be available and you can be a benefit and a positive influence on your facility. So a federal emergency has been declared, is only declared through the National Response Framework, and it will provide a community with specific tasks or specific needs. The NRF is there to support the community experiencing whatever disasters you're having. If you're in Florida with a major hurricane, it will also provide you with help with transportation, temporary housing, medical resources, search and rescue. I know back in 2000 when they were talking about the Y2K happening, our hospital had us, we were all going to be at the hospital. We all had to be on call for the hospital. And our pets, we had the hospital made arrangements with a local veterinary hospital that our pets could be brought there. So, I mean, thank God we didn't need it, but we were prepared. Water can be rendered safe for drinking after boiling it 3 to 5 minutes. And in my class, in gerontology, I was teaching when we were talking pesticides on this one apartment building that is next to a potato field. And every year they go through about 3 weeks where they cannot use their water because it gets into the water system. So they have to boil their water 3 to 5 minutes just to be, and they don't even drink it. That's just to be able to cook with and wash their clothes with. You can also add 1 milliliter of, which is 16 drops of bleach. I'm guessing it's to a gallon of water, and let it set for 30 minutes. And then boiling it and then removing it from the heat or heaters. So when a disaster happens, you have to recognize that everyone is being impacted. So you need to have a firm direction on where you're going, what your job is. So communication is the most important part of dealing with any kind of disaster. Everyone has to be on the same page. I have to know what job is it that you want me to do. I will do anything, but I'm not going to do everything. So tell me exactly what you need of me and I will do it. And then that way you don't have two people doing the same job, you know? Now, a client who's exposed to toxic chemical, we have to make sure that they're, number one, they're out of their clothing. Remove everything, even contact lenses. Everything is considered contaminated. They have to flush their eyes. They go into a shower. The eyes have to be irrigated for at least 10 to 15 minutes. Clothing has to be placed in a plastic bag. Remember, when you're dealing with chemicals and clothing, do not pick it up with your gloves or your hands. Use tongs, because if it's some kind of acid, your gloves are not going to help you. So only use tongs to pick up clothing. Make sure that it goes directly into the bags, the plastic bags. And then disposed of. Now, anthrax is cutaneous small sore that develops into skin ulcers with black centers. That can be seen in biological warfare. GI, the GI symptoms would be nausea, loss of appetite, bloody diarrhea, fever. And then you'll also have, in the deadliest kind of anthrax, there'll be flu-like symptoms, chest pain, and shortness of breath. With smallpox, it will start with flu-like symptoms, but then it develops into a rash with red spots to become deep pustules and leave craters. The thing about smallpox is you won't see them on the soles of the feet, and I don't think on the palms of the hands. Now, chickenpox is similar. It starts with a rash. It has smaller red dots that turn into small clear blisters, which are called vesicles. And then the lesions of the smallpox, unlike chickenpox, can be. Now, this says smallpox can be found on the palms of the hands and the soles of the feet, but I learned it differently. I learned it the opposite. I will look that up and get back to you guys, because I learned that chickenpox can be on the soles of the feet and the palms of the hands. So I learned my memory must be wrong. So let me get back to you. I'll look that up and get back to you. Sarin is used in people with severe respiratory distress. No, sarin is a chemical that can produce severe respiratory distress. It's a toxin. Now, foodborne illnesses, always wash your hands again. Separate raw and cooked food from each other. Thaw frozen food only in the refrigerator. Cook food thoroughly. Do not eat hamburger meat rare. Don't even give it to your animals rare. Do not use food beyond the expiration date. If it's waterborne, Lyme disease is carried by deer tick, and that can lead to chronic neurological and cardiac abnormalities. The Zika virus is carried through mosquitoes, and it can lead to microcephaly, and it can also be contracted by pregnant women. Rocky Mountain spotted fever is carried by the dog tick, easily treated with antibiotics, and malaria is carried by mosquitoes, and it can cause regular cycles of high fever, flu-like illness, and shaking chills. So for week 8, we have 10 minutes. That was about home care, community resources, and case management. So basically the things to remember is home care. There's 2 types. There's the skilled home care, and then there's the long-term care home care. Typically, skilled home care is covered by Medicaid. It's considered like a hospital at home. My first ever home care client, actually, she was not skilled, she was regular home care, was home on a ventilator, and she had a G-tube, and she needed nursing care because for the ventilator and the G-tube. So with skilled care, however, these people need services that are typically provided in the hospital. So in order to be accepted into skilled care, you have to be homebound. Whereas long-term care, you don't have to be homebound. Skilled care is covered by Medicare. Long-term care is covered by Medicaid. Because there are more older adults now, the population has more of them. There's a need for more home care nurses. Now, long-term care home care clients do not have to be homebound. The skilled ones, because of Medicare, has to be homebound. One of the things that we do differently is in skilled care, our number one goal is to prevent readmissions, because every time the hospital has a readmission, they have to pay Medicare penalties. In long-term care, our goal is to keep them functioning at the level that they're functioning now. They're probably not going to get better, and we don't want them to get worse. So if they're using a walker to ambulate, we do not want to see them go to a wheelchair. Whereas in skilled, if they come home using a walker, we want to see them not need their walker anymore and go to ambulating independently. Does that make sense? I'm going to say yes. So home care can be intermittent, especially if it's skilled. You're only going to get skilled home care for a few weeks. Long-term care can last a person the rest of their lives. I've had some clients I've had for many, many years. And sometimes with the long-term care people, they need help with their ADLs and their IADLs, but they also need help with socialization. Many of them are just lonely. I was looking at Obama system at the same time. I don't know where the H came in, but the Obama system is used by community-based nurses, typically used to organize, sort, and document the pertinent clinical data. So Obamacare actually opened up home care. It provided more access to home care. Whereas before that, people really had a hard time paying for home care. So the number one goal, or one of the main goals for home care, is to keep people safe and keep them in their homes. As you learned in gerontology, the biggest fear of growing old is loss of independence. So we strive to keep them as independent as possible. And our goals are typically not for them to not get any worse if they're long-term care, and if they're skilled, for them to get better. Community resources are used to enhance self-care capacity. And that can be health departments, nonprofit organizations, volunteers, Meals on Wheels, Red Cross. I know a lot of the SNAP programs now allow people to get fresh fruits and vegetables at farmers markets. The first step in building trust with a largely non-English speaking immigrant community would be to identify trusted community leaders. So that's important to remember if you're walking into a home or into a certain community. Find the people that have the most influence. If you can find the people with the most influence and gain their trust, then they will speak well of you to the people that trust them. For example, if you're in a home, if your client trusts you, their family will trust you also. Case management. Now, this is why I encourage all of you guys to become nurse practitioners. Case manage with the way healthcare is now, older adults have they see so many different providers. They have a cardiologist, a pulmonologist, maybe they're going to dialysis, so they have a nephrologist. And I can't tell you the amount of times that a specialty will order a medication for a client. I send the order into the primary care, and the primary care will send it back saying, no, they don't take that. I didn't order it. And then I have to call them and say, you didn't order it, but the cardiologist ordered it. I thought you'd want to know. And that's part of the home care job is we are case managers. We have to make sure that everybody's on the same page. That primary provider needs to know what everybody else is doing. And when I was researching for my doctorate, I found out that nurse practitioners make the best case managers, even better than physicians. Because when we go to school, we learn about everything, and physicians will become more specialized. Now, nurses can become specialized also, but our basic education is far more open than a physician's basic than med school, let's say. So case management we are responsible to make sure their medications are reconciled. We make sure that all the physicians are on the same page, all the providers are on the same page. We work with the family, the caregivers. There are usually regular meetings, inter whatever meetings that they have, like you have with school children with problems. Case management can be labor and can be time consuming, but it's the best for the patient. You don't want anything breaking down. The number one thing that you need is good open communication. Everybody needs to be on the same page. Now, for post-op care, we always look for their airway, breathing, circulation, safety, pain. Look for complications. Before we even look at the dressing, we make sure the person is breathing, because typically the anesthesia, I can't even tell you some of the things I ran into. But we have to make sure that they're breathing first. They can come out of the recovery room into ICU and they don't even have they're not even breathing. So that would be first. Your ABCs is first, and then you would check the dressing. When you're, I don't know, do you get into how to prepare for a post-op patient?
Just what's on our notes, we talk, just knowing how to assess a post-op patient.
Okay, so we
Right.
want to make sure there's no DVT. We want to prevent
Yep.
sepsis,
Mhm.
dehydration, urinary tract infections. We also have to make sure they have bowel sounds. That's common that they don't have bowel sounds. They have to pass gas before they can eat. Make sure that the wound is healing well. Pain control is very important. Getting up and walking is probably the most important thing. We want to also control the nausea due to the anesthetic. The way to prevent complications, however, goes back to aseptic technique. Use aseptic technique when changing their dressings. Turn, cough, and deep breathe every 2 hours. Incentive spirometry. Encourage oral intake. Provide pain control, especially if they're going to go for a walk. Usually we would give them the pain medication a half an hour before they would get up and have PT. Also, the cool compresses can help with nausea. I'll always try to eliminate odors in the room, provide ice chips. One thing that I used to do that the doctors would let me do is if somebody was on ice chips, I would crunch if they wanted a flavor because their mouth tastes really bad post-op, I would crush up popsicles and let them suck on those ice chips basically. And that worked well. Because even diabetics, they haven't eaten for so long, so it gives them a little sugar and it helps their brain to wake up, because as I was saying in one of the classes, the brain only uses sugar for energy and it can't store it, so you need a constant supply of sugar. So the practical nursing, we delegate care for the unlicensed assisted personnel during post-op period. So we should give them specific instructions on how to change the dressing, how many times to do the vital signs. Typically post-op, you do them every 15 minutes for an hour, every half hour for an hour, every hour for 4 hours, and then it goes back to every 4 hours, whatever the floor is. We talked about that.
Can I jump in about delegation? Because
Sure.
delegation is covered on the next exam. And so, like Dr. Cupteros just said, if you're delegating, right, what's the one kind of patient you wouldn't delegate to on UAP?
The most stable ones.
The most unstable one you wouldn't delegate, right?
Yeah.
Right. So the important points to remember for delegation, if you're going to delegate, it must be a stable patient, not an unstable patient. Remember, they're working under your license. You need to let them know what they need to do. You need to make sure that they know how to do what you're asking them to do. And that you need to make sure that they know what to alert you of that they would be concerned about. Right.
I have a
Remember,
question.
go ahead. They're working under your license.
How
Go ahead.
many, like in our state, LPNs do not do post-op care. They're not charge nurse in post-op, they're in the hospital. So it's the RN that delegates the, the care. Usually the LPNs are charge nurses in the nursing homes and skilled facilities where there are no post-op.
Yeah,
Well,
that's kind of interesting because some of the NCLEX questions, they'll have like the RN delegating to the LPN, and I get confused with that sometimes because
think about delegation in any way. Okay, so when I was a school nurse delegating, I was delegating clinic aides or whatever, and because we weren't site-based. We had clinic aides in every school. So we were delegating diabetic care. We were delegating how to give an EpiPen, how to give an inhaler, right? But there were competencies that went along with that. I had to make sure that I demonstrated to them how to give an insulin shot. They had to re-demonstrate. There were competencies. They had to fulfill that. And there were times, I had a good handful of times that I had to pull delegation because I instructed them what to do. I showed them what to do. I told them when I need to be contacted. And when those fell through or they weren't accomplishing that through their competency testing, I had to renege on the delegation because they were operating under my license. Does that help, Janelle? Yeah, delegation is
yes,
really
thank you.
important, whether it's the RN to the LPN or the LPN to the UAP.
Thank you.
You're welcome.
So
But the
do you have
funny part
anything
is,
else to
even
add?
though most things aren't even followed through the book, because like even as a post-op CNA for a C-section, we still do vitals even after post-op when we're not supposed to.
Well, remember, everybody has their own, every state has their own scope of practice, scope of care. And so managers, leaders of those departments in hospitals, they have to be aware of what the delegation practices are.
Right, but
Um,
that kind of stuff what you're talking about, Janelle, usually comes under the facilities policy and procedures. And
it's
that's
just
one of
they're
the,
asking the questions on NCLEX and it's given different scenarios, and I feel like I could probably be delegated most of them, but I gotta choose one, and I don't, it's confusing to me sometimes because I don't know.
well,
I
remember,
agree with you. It is confusing, though it is when you try to do the NCLEX questions.
Yeah.
we
well,
all
think of
have,
it this way, as an LPN, your home health aide is more trained than your CNA. Your CNA can do things that the PCA or the whatever they're calling it can do. So you're more intense, you're more acute patients would go to a CNA rather than an assistant to a CNA. Right?
that's correct. And what you really, the reason why we bring this up is it's really about delegation in general. If you're delegating, somebody is now working under your license. So
Yeah, I mean, it's the RN to LPN that gets me, not the UAP.
yeah.
Those are the ones that are.
So standards of care, scope of care. The RN, I had to have a complete understanding of what my scope of care was to delegate. I mean, there were certain things in the schools we couldn't delegate. There were certain things we could, but that was part of our training, competency training at the beginning of every school year. So I would assume that that's going on in the hospital setting or the long-term care setting. But if you ever have a question about what you can delegate or what somebody is trying to delegate to you, you have got to ask. Ask for clarification.
Okay, well, have a good week.
Yeah, you guys have a good week, and we'll see.
And a
We
happy
won't see. We won't
Thanksgiving.
see you for 2 more weeks. So have a good Thanksgiving.
Thank you too,
Yeah.
everybody.
Okay.
Bye.
Bye.
Have a good evening,
Thank
guys.
you.
Reese, I'm going to have you log out, all right, because I need to finish up with this class. And if you could give me about 10 minutes, we'll get together. How's that?
Okay.
All right. See you in about 10